So this is the first time that we have done a hybrid library program like this that's one-off. We've done lots of meditation sessions and discussion groups, but this is the first panel discussion. One of our panelists was online, 3 are here in person. So we just asked everybody to bear with us tonight because we might run into technical difficulties, and that's the world we live in now, isn't it? I did want to tell you about one program you might be interested in. You're here tonight to learn about a good death. You want to take it back one step and learn about estate planning. We have a seminar on that next month on Wednesday, November 17th with attorney Edward Beasley. We have had him here many times to give that seminar, and it's fantastic. So if you haven't started that process in your life, I invite you to come for estate planning. It will be here in the Levinson room. As you can see, masks are required. We love hearing from you about what you'd like to see at the library. So for those of you online, I will share an online event feedback form. For those who are in person, there's a blue form at the end of the Brookhaven table right over there. I encourage you to take a couple minutes at the end of tonight and fill it out. Tell us how you found out about this program, what else you'd like to see us do at the library, and if you give us your email address, we will enter you to win a library book bag, which are made here in New Hampshire. A big thank you to our friends and collaborators at Hospice Health Foundation and Brookhaven Hospice. We really love working with you. And now I'm going to let Kate Swenson Tuttle take it away. Thanks, Kate.
Thank you, Laura. I want to make sure this works, but thank you so much. I can't thank Laura enough for including this presentation as part of their programming and all that the Portsmouth Library does for our community. It's also quite a feat of technology, as Laura mentioned, so we're all in this together, and I appreciate that. I also wanted to thank Marsha Fillion, the Executive Director of Hospice Health Foundation, for co-hosting this as well. HHF, as we call it, Hospice Health Foundation, is a charity organization that boosts the comfort and dignity of impoverished patients by funding essentials that aren't necessarily part of their insurance. So some of the examples of things that we fund are rent, oil for heat through the winter to keep people home, glasses, hearing aids, that type of thing, and sometimes transportation to allow people to have connections with their family at the end of their life. We are based in Portsmouth, and we work with hospices throughout the state and neighboring communities. We also partner with other like-minded agencies. I'm going to use Brookhaven as an example, but other people also working in this field to promote the education around end-of-life and end-of-life options. So I also wanted to make a shout out to my team at Brookhaven Hospice, Sarah Young, my counterpart, who's joining us virtually, and our program director, Angela Cadis, for supporting programming like this. We are an agency that is based here in New Hampshire, across the south. We have offices in Portsmouth, Windham, and Bedford, but we serve much of the state, and we have robust staffing, so we're very available to be responding to keep people home and happy where they want to be, to have their end-of-life experience wherever they call home. So the way tonight is going to work is that I'm going to give a very brief introduction to the panelists, and then we're going to hear from each of them, and they will talk to you more about the work they're doing and who they are. At that point, we're going to ask that you hold all questions until the panelists have had the opportunity to speak, and then we will open it up for discussion. And we'd love to have anyone who is virtual place discussion questions in the chat window, and you're welcome to send them directly to me if you don't want to put it to the whole group or everyone. Either way, I'll be able to collect those questions and pose them out to the panelists at the end. So please do keep your microphones muted, those of you at home, and cell phones should be off here. And without further ado, I would like to introduce these wonderful people who have joined us to share their expertise tonight. We'll start with Michele Lovell, who is a professor at UNH, clinical assistant professor at UNH, and also a nurse practitioner in the Palliative Care Department at Wentworth Hospital. So she'll talk to you more about her work. Sandy Lafleur, who works with the Threshold Care Group, is over from Wilton, the other side of the state. So thank you for joining us tonight. Also does music therapy, so we're going to hear more from Sandy. Elizabeth McCue is joining us as an end-of-life and grief coach. And we have online virtually on this presenting via Zoom, Rebecca Brown from the New Hampshire Alliance of End-of-Life Options. So there's Rebecca. So that works well. And so hopefully we'll all be able to follow along. And without further ado now, I guess I'll introduce Michele. So Rebecca, what we don't see is the slide deck. Is that visible to the folks?
Yeah, now is a good time, Rebecca, to start, yep. And we've had someone ask on the chat to make sure that we speak slowly. Unfortunately, it sounds like there is a little bit of an echo with the audio, which I can't do anything about. I wish I could, so just let's make sure to speak into the. Okay. Thanks.
So actually, I was going to introduce this way without the slides. So I would just also wanted to highlight the reason for this panel and bringing this group of women together is to really entertain the option, different notions of end of life options and planning. And if you could, Rebecca, go ahead to that fears of dying. So we each have had an experience with death, presumably at some point in our life, that has probably also impacted how we think about death and dying. So it's important to consider those aspects of things in your own thinking of your own end of life. And we all have fears surrounding that. So there's a lot of anecdotal fears that people share about their end of life concerns. And I think we just wanted to highlight the importance of planning and being able to communicate with your loved ones and friends about these different fears, because by verbalizing it, by understanding options that do exist, you know, and planning as best we can, hopefully that will inform all of us to be able to live more fully and let go of some of those fears. So that is why I think it's so important to bring you all here to hear. And now we can move forward with Michele, starting with palliative care discussion.
Well, thank you, everybody. As you heard, I'm Michele. I'm a assistant professor at UNH, where I teach death and dying, and I have taught that for probably a decade now, and most recently started a palliative care course for undergraduate nursing students. I'm really, it's my honor and pleasure to be here with you tonight to talk a little bit about palliative care. So if we could advance the next slide. First, I can't see everybody online at home, but who here, if you could raise your hand, has heard of the term palliative care? So just about, I think it's 100% of the audience here. And that is good news, because even 10 or 15 years ago, if I asked that, maybe a hand or two would go up. And there were a lot of misconceptions about what palliative care actually is and was at that time. So you can see on the slide a couple of definitions up there that come from clinical quality guidelines. There are several think tanks that have defined palliative care, but what you can see from the slide there is that palliative care is really a specialized form of care that is geared towards patients and families that are experiencing serious illness. And that's kind of the catch-all, serious illness. It really doesn't depend on prognosis, meaning how much time does a person necessarily have until the end of their life, but it's geared towards optimizing quality of life as that particular person defines it for themselves, while at the same time minimizing distressing symptoms. And by distressing symptoms, those can be multifaceted: physical symptoms, psychological symptoms, social distress as people's roles change, and spiritual concerns. This type of care is offered by clinicians who have special training. And it is what we would call an interdisciplinary team, meaning we have physicians on the team, nurse practitioners, nurses, social workers, chaplains. We also bring in many different disciplines such as occupational and physical therapists, integrative therapies, speech therapy, just about any type of area of expertise that would help a patient and family try to reach their own goals based on their quality of life concerns. So again, kind of a holistic approach to care, offered by many different types of clinicians. Can advance the slide. And I like this slide. Actually, my mentor shared this with me many years ago, because when I think about the type of care we provide in palliative care, we have a small percentage of patients that actually have a serious illness that may have a curable disease. But we still see those patients because as they are going through what can be really tough treatment, they may have distressing symptoms related to that treatment. And so we want to help and support them through the treatment so they can reach that goal of cure, because that's typically their goal. And then with the bulk of our patients, we are relieving symptoms often. So whether that's physical pain, spiritual pain, anxiety, confusion, distress, fatigue, any type of feeling or concern that a patient may have, we are trying to step in to support them and minimize those symptoms while trying to optimize quality of life. And then for everybody, all of us here, you don't need to be a palliative care clinician, but we try to always provide comfort. So that's kind of the stepwise fashion that I like to think about it. If we advance the slide. The integral pieces here are what you see up there: patient, family, and team. So when we think about the person that we are caring for, it's that individual who has the serious illness, but just as important is the people that they consider their family. And this could be family of origin, family of choice, but anybody that that person feels is important in their life. That family kind of walks side by side with us in providing care to a patient to, again, lift up their quality of life. So they are an integral source, and we try to support not only the patient, but the family as well. That's a big part of what palliative care does. And then again, it's team-based. So this is not any one person meeting with a patient and family and trying to develop a plan of care, but a constellation of people, depending again on what the patient identifies as their biggest concern. Next slide. So this is a question that I used to get a lot a decade or more ago, because a lot of people misunderstood the difference or felt that palliative care was the same as hospice. So a lot of times I would come to meet a patient or family and they'd say, whoa, I don't really want to see you because, you know, I'm not quite there yet. And so palliative care and hospice have a lot of similarities in the idea that we approach care from a holistic standpoint with a multidisciplinary team. But you can see up on the slide there that there are some pretty big differences. Palliative care is offered to a patient of any age with a serious illness across the span of that care. And that can be for years. Hospice care is provided to a person of any age who has a prognosis, meaning a life expectancy of 6 months or less, as kind of determined or considered by two providers. So that's one of the big pieces. The other big piece is that palliative care is offered to someone with serious illness alongside with any other type of care that is meeting their goals. So oftentimes we'll have a palliative care patient who is receiving pretty aggressive therapy, and we are walking side by side with them along with that treatment team to, again, make sure that the symptoms they're experiencing can be treated so they are feeling better and they can continue to receive their treatment. So we will have palliative care patients in the ICU sometimes. Whereas with hospice care, when a person elects hospice, they're really focusing on comfort, quality of life, spiritual, social, psychological concerns, life closure, and they are no longer seeking curative or what we would call disease-modifying treatment. So that's kind of where palliative care and hospice often split. So again, we could see someone for in palliative care for years, and we have patients that we see for years. Whereas with hospice, there's a defined kind of time expectation there. But again, the type of care is the same, that it's holistic, focused on the patient and family. So this is a great image, which I think if you're a conceptual learner, this is helpful because we have that big circle, right, that represents palliative care, right, the care of anyone with a serious illness. And then within that, we have a smaller circle, which is end-of-life care. This is care that is offered to people and they receive as they approach end of life and at end of life. And within that smaller subset is hospice care, a very specific delivery of care that someone elects at the end of life. So when we see this, the notion is that palliative care is the type of care that is offered in hospice, but not all palliative care patients are hospice patients. In fact, it's kind of a small subset that actually are hospice patients. Next slide. And this is another, if you're a conceptual learner, this is a nice one too, because you can see at the start of an illness, that's a serious illness, you of course are receiving treatments to try to modify that disease, hold it at bay so that you're reaching for longevity of life and quality of life. So as you're receiving curative treatment, you also can start receiving some palliative treatment. And the palliative team walks along with you along that journey as you're receiving both curative and palliative treatment. And then as we approach the end of life, that last 6 months, this is when someone may consider hospice. And that benefit is provided during that period of time. After the death of a person who was receiving palliative care, but especially hospice, there is a period of time for bereavement care for the family. And that's really a special benefit that hospice offers to families. Next slide. I just put a couple of comments up here from patients that we've cared for in the past. The top one really speaks to a patient that had some, was actually hospitalized with some intractable, really distressing symptoms, not just one, but kind of a constellation. So we worked for several days to try to get these symptoms manageable for her because she was approaching end of life, but her daughter was graduating from BU in like 3 weeks. And that was her goal, was to try to be there when her daughter was graduating. It was kind of a big life event. So the whole goal of the hospitalization was to get those symptoms manageable to help her reach that goal for herself and for her daughter and family. And then the next two quotes, one is from our patient himself, who gave a letter to his daughters to give myself and the physician 6 months after his death. And he talked about how his experience with our team towards the end of life, he thought it was going to be the worst trip he ever had, and it turned out to be one of his best trips. And then his daughters wrote, you know, thank you so much for having us be with him on this journey. That's the end of my section. Thank you.
Well, it's wonderful to be here tonight, and thank you all for coming. I'm Sandy Lafleur, and I am involved with a group called Professional Care. My experience with end of life, like probably a lot of you, has been impacted by experiences with family and with friends. And each one of those experiences shaped my thinking about how I would want to spend my last days. And I've watched a very, very moving and powerful film, which I had told you about, called Holding Our Own. And it's about end of life and about a group of singers that would come and sing at bedside. And being a musician, this really spoke to me as a way to share a gift with somebody at the end of their life. I wanted to show this film as part of the Sunday documentary film series that I was running in Wilton at the Town Hall Theater. And so I spoke to a hospice in Merrimack, and they said, well, we have that film. We have one with the commercial, the community showing rights. And so they let me borrow it, and they came and had a wonderful conversation with about 30 people after the documentary. And through that, I met some other people, individuals, women in my community who were starting to think about putting together a group to really explore end of life and how to support people end of life. And so that was how Threshold Care came about. Another interest of mine was the environment. And while we're not really talking about what happens after the end of life, this is kind of pivotal for me. I really wanted to do something with the group that was concrete, only without the concrete. So I was looking at green burial, and I wanted to see if I could get that to happen in my town. And with the help of another member of our group, we went to the cemetery board of trustees and asked about it. And without too much trouble, really, it happened. And so if you're a resident of Wilton, you can be buried in the green burial section of the cemetery. But what this brought to mind was that you can't just do this anywhere, anytime. You have to plan. You have to start thinking ahead. And about the same time, a couple members in the Threshold Care group were working on this end of life planning guide, which we sell on a sliding scale. And this is it's a workbook. And it covers all the planning, things that you might not think about, in the days leading up to my death, at the time of my death. Where do I keep important information after my death? So these things are conversations that we all have to have well before we get to a point where we're staring at that, okay? The idea of a wisdom will. We talk about what we're going to leave to our aunt or our daughter or our son or whatever, but what about the wisdom? What messages do we want to leave? So that's another thing that this brought about. We have choices, and I think that's the powerful thing, is to know that we have choices. The idea that when someone dies, that the phone is picked up and it starts the whole process that has been preordained, we think. But no, we have choices. We have choices in the way we want to be cared for at the end of our lives. And so we need to learn about them, and we need to talk about them with our families, because otherwise they're not going to know. People think it's maybe a little bit selfish to think, well, this is what I want, this is what I want, this is what I want. But it's actually a gift to the people, our loved ones left behind. They don't have to second guess. You're telling them exactly what your preferences are. And that can be really, really helpful. So I've done some trainings with different groups, most recently a certificate course through UVM as an end-of-life doula, and have done some work in that regard. And so the doula work is support of the spiritual and physical needs of the patient and the family, and it's very much individual because our life experiences and our death experiences are all very individual. In the most memorable doula experience I had, one of my jobs was kind of a gatekeeper. And what that really was kind of a coordinator, if you will, to support the family, what needed to be done, and who you have for resources that could fill those roles. So what this did was free up the family from having to make all those phone calls, make all those emails, so then they could spend their time, the quality time that they wanted to spend with their loved one. And that was very, very freeing and very important, which I was really impressed upon me afterwards, how helpful that was. Just sitting at the bedside, playing music. My instrument of choice is the Appalachian dulcimer, which is very soothing and calming. And I see some nods. Yeah. I just received a card just the other day from the sister of a woman I cared for. And she said that one of the most memorable moments that she had, the time that she had with her sister as she was dying, the two of them were in bed together and she was holding her sister. She thought her sister was asleep or unconscious. The room was darkened. There were some candles. And I was just sitting quietly and playing and watching. And it's a conversation between the musician and what's going on in the room so that it's appropriate. And that moment was really, that time was really important to the sister. Very comforting. End of life can also be a very wonderful time for growth, spiritual growth. It can also be a time of healing, where families can find a way to come together. So we all often think of death as just a negative, you know, it's the end of a life, but there's so much that can come from it if we let it. So I guess that's really what I have to say. And having this conversation, this is the fact that you're all here and people are on Zoom and we're interested in this topic is really fantastic, because by talking about it, we're breaking down the stigma of talking about end of life. And that's really important. Thanks again.
Thank you. I was just thinking recently about Ars Moriendi, the Latin, the 1400s, the art of dying, and we'll talk about the plagues and all of that, and how obsessed with death people used to be, but we've swung way to the other extreme now, and it's just, it's verboten to talk about death at all almost. So it's nice to hear what you were saying. You know, someone was saying, I'm 75 years old and in great health. I don't want to talk about death, which is true if you don't think about death until 2 weeks before you die, then sure, you don't think at all about your belief system or spirituality or medical ethics, unresolved conflicts, then sure, it's too soon to think about it. But then you're living in fear, essentially, of death, and you're not ever experiencing the relief or the transformation that comes from actually talking about those things that are in the back of your mind anyway. So that's the end of life. When I say I'm an end of life coach, that pretty much, it stops a superficial conversation for sure. And an end of life coach, I was a hospital chaplain and I had a massive brain aneurysm, which put a stop to that. And when I started coming forth to do something, I heard, you know, I knew I wanted to stay as a chaplain. Essentially, I thought I want to be a solo chaplain, even though there was no such thing. Along those lines, when I heard of end of life coaches, I thought that just sounds vaguely sort of obnoxious. I don't know. I didn't like the sound of it at all. And I didn't like what I heard about coaches, because I knew of people going to a couple of webinars and then being a coach, and I just didn't respect it. But I didn't know about the depth that the field can take in training and certification and what it could mean. And I learned a lot about what does it mean? What is a coach? And for me, in terms of end of life, what I learned it means is, as opposed to counseling or therapy. Now, I'm one of these people who's very pro-therapy. I've benefited from it myself, and a lot of people in my life have benefited from it. And I'm the first person who would say, let's find a good therapist for you to deal with this or that. But when it comes to illness and end of life, that's a perfectly normal part of life. There's no reason to pathologize it if it's just part of a normal life and the person is fine. And in coaching, the idea is you don't need to be fixed. You are a perfectly whole, resourceful person going through this particular part of your life. And with coaching, you can get from here to there faster with coaching and the proper listening and questions. It can help you clarify what you yourself are thinking and feeling faster, and you can make your own decisions about what you want to do, about what you're feeling. You don't need someone to tell you what you should be thinking and feeling. You don't need someone to hand you the answers. You can arrive at your own answers. That's the difference. And so now I will call myself an end-of-life coach. And as far as talking about things, about end-of-life issues, I will end with telling you that when my father was dying, I was by his bedside for a long time. He had Alzheimer's, and we were a great father-daughter team. We always got along and all of that, but we were very typically Irish Catholic, I guess. We never actually discussed the fact that he was dying. You know, that would have been going a little bit too far. And yet at the end, he was holding on from, and he was in that last phase of dying, and yet he was sort of holding on. And I knew there were a couple of things that he might be thinking about and refraining from dying because of. And even though he wasn't communicative, I knew he was listening still and hearing everything. That's what people do. And I finally went in and talked to him about some things and discussed those matters that I thought he might be thinking about. And shortly thereafter, a friend of my mother's came in and did some Reiki on him. And he died. And I'm telling you, it was like, Houston, we have liftoff. It was like the most incredible thing I've ever experienced. It was something I always dreaded when that my father would die, and the air in the room changed. It was absolutely joyful. So I personally and wholeheartedly recommend discussing things with family members.
You want to speak about that?
Oh, that's just an example of something that's easy to talk about. Yeah.
All right, Rebecca, you're up.
So I can see some people on Zoom, and I'm pretty sure they can see me. How about the people in the audience? Am I on a screen somewhere? Because I can't tell.
You are.
Yeah, we can see you.
Okay, hi. So I'm Rebecca Brown. I'm talking with you from Sugar Hill up in the White Mountains, where it is absolutely glorious. And if you want to come up to see the peak foliage, you're right in time this weekend, and everybody else is left, so it's perfect. So I invite you all to come and visit. I'm going to tell you about the New Hampshire Alliance for End-of-Life Options, which is a new organization. And We have just gotten started in the last year. We are very new. We are grassroots. I come to you as a resident of New Hampshire who loves this state, has worked here for many years on many types of hopefully positive change in our communities, especially around the environment. And you can read our goal that New Hampshire residents, all of us, are able to make important decisions about our bodies, our spirit, and our emotional well-being when we're nearing the end of life. But I'd like to really start by sharing our vision for this, which is that New Hampshire, our state, is a place where people are inspired to live life fully and completely and enjoy the best quality of life possible right to the end. And we believe that being forthright and honest and having less fear and anxiety around end of life is part of that, of living life fully and completely. So I've been asked to talk about medical aid in dying, which is a tool in the toolbox of living life completely, because it brings to residents of states where it is legal, medical aid in dying allows people another way to bring their own personal autonomy and decision-making and choice into their lives around when and how and with whom they want to end it. The last year, this year as well, has been with COVID, a whole lot more people are dying unexpectedly and at a young age than has been the average for quite a while. So I think this issue is certainly something that is on the minds of people who may not have thought about it before. But the principle is, whether we have medical aid in dying law or not, and currently we do not in our state of New Hampshire, that no dying person should have to endure more suffering than they're willing to. And that everyone who is mentally competent should have the right to die, if possible, in a way that we decide and control for ourselves, consistent with our own values and beliefs. And I just want to underscore this: there are many ways to die with dignity, and a medical aid in dying law is a tool in the toolbox. But right now in New Hampshire, we have to think and look at other ways, even as we explore whether medical aid in dying is the right choice for our state. So the medical aid in dying laws, as written in 9 states, including Vermont and Maine, is pretty clear and has a lot of safeguards built into it. First being, you have to be at least 18 years of age. Like hospice, it is a 6-month prognosis, 6 months or less to live. A person must be mentally competent. There are very good safeguards, strict safeguards about people who are not mentally competent being, somehow forced into a decision that they wouldn't make. A person must be able to self-administer the drugs, which means they have to be able to actually lift the cup to their mouth. They need to be able to swallow. They need to be able to have the use of their hands. And it needs to be a clear system of a written and an oral request. There are physicians involved, and this is a law, it's written in statute in the state, and there are very clear procedures so that there is not an issue with people being, somehow coerced. So I am happy to answer questions about the medical aid in dying law as it is written across the United States and as we're thinking about it in New Hampshire. But the New Hampshire Alliance for End-of-Life Options came together as a grassroots effort with a broader mission than medical aid in dying. And it really goes back to that goal that I stated in the beginning, that we are all able to make important decisions about our own bodies, our spirit, and our emotional well-being. And we're doing this as a grassroots movement. We believe that we, as consumers of medical care, consumers of healthcare, have a tremendous amount of latent power to influence our system. And I am proposing to you that what we're looking at and what we need in our state, I think we need in our country, is a change in culture as it relates to death and dying, with less fear and anxiety, more honesty, more forthrightness, more patient choice, informed consent, and shared decision-making, so that we as consumers of medicine or patients are able to make decisions that are best for us. It's time to stop treating death like a failure. Time to bring it back into our lives, into our homes in a more, I'll say, whole way. And we believe that can start, it has to start with us as individuals thinking about our own values and principles, what quality of life we want to experience, what makes life worth living, what would cross that threshold for us. And that's hard work. It's challenging work. And how we talk about that, how we share that with the people who matter most to us, so that whenever we face the end, we have some clarity and some support from people around us, and leave less chaos around what did she really want, or what, we've all been through it, the conflict in families. We wish that there had been better, more clarity. And to talk to our doctors in the same way and really be clear about the kinds of things, the kind of good questions to ask. So bottom line is, we believe it's time for a grassroots effort in this state to begin looking at changing our culture. If that goes in the way of medical aid in dying, which we believe should be an option here, but it's an option. If you want to avail yourself of that, you have the right to do that. If you do not want to avail yourself of that, you have the right to do that as well. It's really around individual choice. And I just would like to transition this by saying, everybody's talked about it a little bit tonight, that planning is really critical, and looking ahead and starting to have these conversations with the people who matter most to us. And that is where we are starting our work with community conversations around advanced care planning, how to have those challenging conversations, a little role play about, how do you talk to your kids about this stuff, or your spouse? How do you choose a medical proxy, someone who's really going to represent your interests when you can no longer speak for yourself? And I think Kate is going to pick up on that. Are you ready to do that, Kate?
Sure.
Okay.
Thank you, Rebecca, and the three of you for sharing. Oh,
Just trying to put that, it's hard to see the other one.
sorry.
That's okay, thank you.
So yes, so thank you to all four of you for sharing your expertise in this very delicate topic. But I think it's very clear to all of us that the concept of communication is a key element through all of the different approaches that we've addressed. And something that is a passion of mine, I did not introduce myself properly in the beginning, but I am a palliative care and hospice nurse. Had worked in a hospital setting for 10 years, and now I work out in the community, more focused in hospice. And part of the work that I do is about advanced care planning and promoting for folks the understanding of all of the different elements and implications around the, and the importance of these directives. So in the way that Sandy talked about it from a planning guide, there are so many different ways that we can be communicating with our loved ones about our wishes. And we just thought it was prudent to highlight what advanced care planning is and the importance of that, in addition to what each of these folks is contributing. So I just wanted to address the paperwork that many of you probably are familiar with, the advanced directive. And I would highlight that advanced directive law and the actual document was recently updated by the state of New Hampshire, and there is a new version and it has a different law. The old ones are all still relevant, but if you are interested in updating, they are available, and there will be resources posted at the end of the presentation. So that is accessible and doable without an attorney. I think that's really important as well to note that naming a decision maker in the event that you can't speak for yourself is the most important thing. And you also have the opportunity to give some guidance to that person who might have to make some decisions for you. And that's very much on the clinical side of things. Still very important. Also the obvious elements you could join for the library's presentation on estate planning. Also something important in this day and age is creating a digital footprint. So making sure that someone has access to your passwords and login information for all the important things that you may do online. There are other forms that are important to talk about with your physicians. The do not resuscitate is not part of the advanced directive. A lot of people think if they have selected the option that they would not want life-sustaining treatment, that they have a DNR in place, but that is indeed a doctor's order. So make sure if that's something that you're considering that you address it with your physician. And the PULSE form is also a DNR in a different way, but you can ask your doctor about that. It's a whole different conversation, actually. It's another talk. Obviously, the discussion about green burial, cremation, the different methods that Sandy mentioned about that element. There are people out there doing a lot of work in that regard. Also important to research and talk about. So all of these things I think are just really part of that advanced care planning overview. So just wanted to touch on that. Rebecca, if you could advance, please. There was one slide in between there, I believe, specific about the advanced directive. I mentioned about choosing a durable power of attorney as your decision maker. That is the most important, because if you do not indicate who you want to make decisions for you, if you are unable to speak for yourself, there is a hierarchy and it will be appointed for you, that decision maker. So it's not, sometimes it's not always who you think it should be, that decision maker. So that's also a really important consideration. And the documents allow you to give some guidance and also limit decisions that your decision maker can make for you. I'm going to echo what Sandy said, that all of these conversations and planning is truly a gift to your family and your loved ones. It really takes the burden off of them if they need to make hard decisions for you. And the paperwork specifically is really only used if you are incapacitated and unable to be speaking for yourself in whatever format that is. So we like to look at advanced care planning and advanced directives as a process to think about, to talk about, to plan for the, that eventual end of life, which will come for all of us. And anyone over 18 can have an advanced directive and should have an advanced directive, really. So I also wanted to highlight that there is, in the more recent years, some folks who have been working on a dementia-specific directive, which is very cool. There are documents out there. Dartmouth has one. There's a few others that I have as resources for you as well, that take you through the process of thinking about and understanding if you were to have dementia and the normal disease process of dementia, the things that would become necessary decisions for your loved ones. And so you can talk with them about that and put that all in paper writing ahead of time, all extremely important. So if you wouldn't mind, Rebecca, moving forward once more. I just wanted to sort of wrap up the conversation before we get into some questions. And just looking at the fact that every one of these conversations and these folks who are participating in different end-of-life options are asking every one of us to reflect on our values, to consider our principles, what is most important to us, and what are the elements of our life that we want to have in place at that point of our end of life. So I think the importance of considering how you make decisions, with who you want to include in those decisions, considering what's important to you in your independence or how you want to be living. You know, as Mary talked about, the importance of the spirituality piece, the communication which runs through for all of this, and really considering what it means for you to be living life. We in medicine can do a lot to keep people alive, but having your own definition of what that looks like to live life. And also to think about whether quantity or quality and the things that come with that. And so for a lot of folks, it's just having more conversation, also from a medical perspective and with your physicians about what that would look like, but looking inward and being able to utilize some of these other resources that we are all learning about. So thank you all on that note. And there are some really great questions coming in on the chat. And I think I'm going to jump in and answer one of them before I pass it over. Somebody asked if I could explain more of what a POLST is. So it used to stand for Provider Order for Life-Sustaining Treatment, but they have removed that acronym and it is just known as POLST. Kind of hard word to say actually, but it's a national document, and New Hampshire has adopted the National POLST form. And essentially it takes all of the information that is presented in the advanced directive, except for your naming your decision maker, and puts it in a form of medical orders, doctor's orders. So utilized mostly for folks who are living in facilities or spending, going through a palliative, and I'm going to defer to Michele on this because you can talk about it. I'm sure you have many of these conversations with folks, but it allows us to take that general overview of planning and put it in a set of doctor's orders to be honored in the, if you are in the hospital. Do you want to expand on that?
Yes, so the POLST form is really for someone who may have a life expectancy of a year, 2 years, 3 years, and is experiencing a serious illness and wants to have some clear parameters around expectations for care. So not only does it helps clarify your resuscitation status, do you want an attempt at resuscitation or not, but it also asks you to consider, do I want care provided in the hospital, or do I want to stay at home, wherever that home is? That could be assisted living, it could be a nursing home, it could be your residence. Then it also asks you to think about, if I go to the hospital, am I okay going to the ICU, or I just want to be on the general medical floor? And then from there, it asks you to think, would I want antibiotics? Would I want artificial food or fluids? Are there any other treatments or interventions that I want to mention that are okay for me to consider or off the table? And so this form is filled out with a clinician in a conversation. Again, it's a process. And so once it's completed, the clinician signs it, the patient or their durable power of attorney for healthcare signs it. So I did a lot of these forms in dementia, medical model, nursing homes, assisted livings, where the patient themselves could not participate in that conversation because of their advanced dementia, but their durable power of attorney for healthcare could, and wanted to really think deeply about what is the best care for my loved one. And let's make some decisions around that so that in the moment we have a plan in place.
Michele, I'm going to jump on that last statement you made. Somebody has asked, are there any approaches to help people with dementia transition? Recognizing that none of the options that we are talking about tonight really present a practical way to help somebody who's been very clear in their desires to not linger in their body. I think medical aid in dying obviously is not an option in New Hampshire, but the question is, I am without real options to honor my mother's desire and help her leave her body. Is that something that, I mean, it sounds like it's been a conversation that you've addressed with somebody who's already advanced.
Yes, so in that case, if there is a person who has advanced dementia and can't participate in that conversation, but their decision maker with the family, you know, because it's hopefully a bigger discussion, can complete that post with a clinician, a physician, a nurse practitioner, or a physician assistant, to again, put some parameters around that. And these are tough discussions. These are, okay, if mom or dad has very limited mobility, but falls and breaks a hip, do we go to the hospital? And everyone's gut reaction is, of course we go to the hospital because we have to figure this out. But then we start walking down that path of, okay, well, what is the goal of care when we go to the hospital? Because we can fix the hip. The surgeon will fix the hip. But what is the goal? Is it for mom to kind of return back to that state that she had before? Because that will be very difficult. So it's kind of walking through, if mom or dad or my brother or sister gets pneumonia and has dementia, do we treat it with antibiotics, or do we instead treat that fever, treat that shortness of breath with comfort medication and support instead of antibiotics? So they're big discussions that, you know, we start talking back and forth, and the clinician, if they're skilled enough, can kind of pull out, well, if this happens, what do you think your mom would want? And it sounds like this person asking the question had a clear directive from her mother that, you know, I don't want to linger. So you can put some parameters around care.
I hope that answers.
I'd like to just add to that, if I might, that, you know, when we bring up a topic of medical aid in dying, people say, oh, I want that for myself because I'm scared to death of Alzheimer's or dementia. You know, one of my parents had it, or a grandparent, or a spouse. And it's very clear that the medical aid in dying laws as written do not apply once you have lost the mental capacity and competence to make these decisions. And there is an enormous debate among ethicists and lawyers and physicians right now about, I'll just use myself as an example. My mother died with Alzheimer's. This is one of my real concerns. I can write an advanced directive for dementia today very clearly, and I've done this. It really spells out, if I get to this certain point or points, I do not want to be given any kind of curative care. So if I get pneumonia, make me comfortable, but don't treat it, okay? It is very, as we're hearing, it's very difficult once you get past that point of competence to know that those directives are going to be followed for all kinds of reasons. And so there are more people addressing the question of what I can say today, but if I get to the point where I am in an institution and unable to care for myself and appear to be happy, and am way beyond the point where my today self would have said, if I ever get to that point, you know, like I want to check out. We're really wrestling with these kinds of questions because, of course, more and more people are suffering from cognitive decline. And by the way, we're living longer, but we're not living younger longer. We're living older longer with more disease and frailty and you know, a lot of maladies. So this is something that we in the Alliance are really trying to explore, to open up this question of what are other ways that we can exercise autonomy and have our wishes followed. So big question. No easy answers, but I think very, very pertinent to this. And starting with really clear advanced directives, putting them on video. So you are speaking to your family and your physicians and caregivers. Here's what I want. And, you know, there are all ways of just trying to have these conversations before it gets to the point where you can't, where that competence question is. And I want to let others respond. And then there's a question that came into me that I'd like to come back to, Kate, that's also a variation on this. That's a good question.
I wanted to offer opportunity for somebody present and here, if there are any questions before we go through the others coming in.
How difficult is it today to get a palliative provider? I know lots of different hospice companies that I've talked to do not provide palliative care, and that there is not a specific group that actually provides palliative. So how difficult and how do you go about finding those providers?
That is a great question. And I will tell you that what you're experiencing is not unusual. They're just, like we're hearing with a lot of things, there just aren't enough clinicians right now. I'm part of a hospital-based palliative care team. We used to go out in the community, but because of how much we have been needed in the hospital, we are not doing that. Some hospice agencies will have a palliative care kind of arm of the organization. One good resource is a website called getpalliativecare.org, and you can actually put in and search for palliative care teams in there.
Because a lot of times when talking to hospice companies, not Brookhaven, but other hospice companies, they say they have palliative, but they really don't.
Yeah.
It's very, you know, it's very loose.
I'd be really interested to speak with you more about this
Okay,
offline, if that's okay. It's
perfect, yeah.
very interested because I agree with you. I think there's a lot of room for improvement and we need to have some clarity around that.
So it's Get Palliative what?
Getpalliativecare.org.
Great.
Thank you.
That's a very reliable site.
Thank you, Laura, for posting that to the chat. So there are a couple other questions that have come in for Sandy and Mary Elizabeth. So Rebecca, I was going to come to them and then is that okay to circle back? So somebody asked if you could speak a little bit more about the green burial, Sandy.
Sure, I'd be glad to. So the 3 tenets of green burial: an unembalmed body, and this is totally possible and feasible, and there's no reason why a body needs to be embalmed. And in fact, you could even have a home funeral, people do, for 2 or 3 days, have a wake, and the body is kept cold with ice, so the embalming is not necessary. So that's the first part of a green burial, is unembalmed body. The second one is a biodegradable container or shroud. Can be even, they have cardboard caskets that people even in ahead of time when their families decorate. And of course, what does that tell you about the cost too? Okay, yeah, big difference there. And the third thing is the vault. So no vault, and a lot of people don't realize when they go to a burial, the ground is open and they don't really even see the vault, but there's a concrete vault, and every year we bury tons and tons of concrete, steel reinforced concrete. And it really, there isn't really a good reason for it. When went before the cemetery trustees in Wilton, they're like, well, we're totally fine with an unembalmed body, and we're totally fine with a biodegradable casket, but you have to have a vault. And I said, no, actually you don't. We went back and forth, and they said, look, it says so right here. So see, it's written right there. But I pointed out that those were their bylaws. And since they were their bylaws, they could change them. And it's not required in the state of New Hampshire. So then the question was, well, then why are we doing this? The reason is, after a body decomposes, the ground settles. So a vault makes it easier to mow.
Sandy, can I jump on what you said, just to say that, stand up here so people can hear me better. The Portsmouth Public Library has hosted, I think, twice, yeah, Marcia, green funerals and burials, and do you remember off the top of your head the speaker? He fantastic.
Webster.
Lee Webster. And so we recorded the audio the second time we had that program, so if you are a fan of podcasts, if you can search for our podcast on any platform that you listen to podcasts, it's called The Parrot Unbound, but if you listen to, or if you search Portsmouth Public Library, you'll find it. And so there's like an hour-long episode that's just a recording of that talk. But
What's
we'll
it
have
called again?
green funerals and burials. The podcast is called Parrot with 2 T's Unbound. And at the end, I can throw a link in the chat, but I just wanted to say that she gives a lot of specific information about this area too, which is really nice. Yeah.
She is fabulous and she has so much knowledge. There are several different ways to have a green burial. One can be in your own property. Again, that requires advanced planning. You need to have it written into the deed of your property because you need to have public access to the grave site afterwards. That's not for everyone. It was probably fine back in the day when there was the family farm and everybody, you know, generation after generation, and you see the small cemeteries. But that's one option. Another option is in a cemetery, an existing cemetery, which is what we chose to go for in Wilton because it was the easiest. The third way is a conservation cemetery, where you partner with people who are trying to preserve and conserve land and get an easement for burial on those places. The income stream from the burials helps to support the conservation efforts, and that land will never be developed. It doesn't look like a cemetery. It looks like conservation land with trails, and these are starting to be more and more popular, but they take time and they take money to put together.
There is one in Dover, actually. I happened to attend a burial there and it's behind the Walgreens and it's in a very unlikely looking field, but it's a very beautiful place. So thank you for that.
But doesn't this belong to the Quakers? And you have to be a Quaker?
You do not have to be a Quaker, but it is, I don't know the whole ownership, but yes, I believe it is part of, owned by a Quaker organization.
Oh, I totally have to be a Quaker.
I don't believe so, but I could be wrong. But we can talk about that more.
But just one last little piece is if you wanted to be buried in Wilton, you couldn't be unless you were a Wilton resident, which is why it's really important that you can go to your own cemetery trustees and say, how about green burial in my town? And so if people are interested, contact me, and I've done a lot of presentations for cemetery trustees.
What are you doing about the mowing?
Well, so in Wilton, very quickly, they have a section of green burial spaces. And when it's filled, they're just going to leave it and they're gonna let the woods come back over. No gravestones, there's just corner markers, very small. But our cemetery trustees said, like, we just throw more dirt on it. We just throw more loam on it, that's all. Yeah. Thank you.
Sandy, one more question, just before we move on from you about music and how does music support somebody at that end of life process and techniques, if you could just speak a little bit about that, a couple minutes.
Sure, so I think I like to come into a situation well in advance of the end of life to make a connection with the person who's dying and learn about what kind of music they enjoy. And at that point, I'm really trying to make a connection with them. So we talk about music that they like, something, you know, it can be an icebreaker, it can be a distraction. Further on, when there's pain, when there's discomfort, music, or agitation, music can take them from a very agitated space to a very calm space by bringing the tempo of the music down, matching where they are, and then bringing that down. And it's been shown that it actually can replace some of the opioids that are needed. You know, you reduce the amount of medication that's needed. At the very, very end of life, we're not trying to hold them here. We're just trying to let them go. And so the music is appropriate for that. Very arrhythmic, and just a sending off.
Thank you. And to Mary Elizabeth, somebody was asking if end-of-life coaches are available through hospice. And if, I guess if you could speak to how does one find an end-of-life coach?
Well, generally speaking, hospices do know about end-of-life coaches because there's a good relationship there. Well, that's a good question. Generally speaking, or through hospitals, this is just generally speaking, through hospitals or also funeral homes, that sort of thing. They will know about coaches because another part of this is grieving for people who've lost somebody. There's a lot of coaching there. Like I facilitate a group for children who a parent or a sibling has died. So funeral homes know of somebody, but people can get in touch with me somehow if anybody's interested.
Okay, thank you. I would answer the question specifically about hospice to say that hospice teams do not provide specific end-of-life coaching in the way that Mary is describing, but we do help find people resources that will accomplish what they're hoping for. And so that would be connecting a hospice patient with somebody like you, Mary, and as an end-of-life coach. And one other question for you is about how much do you focus on the spiritual element of things in your end-of-life coaching versus other elements?
Well, I personally am also a spiritual director. So if someone's interested in that, I'm very spiritual and very interested in going in that direction. But I also am comfortable with people who, you know, find the divine in nature or higher power or, you know, a nun, N-O-N-E, no religion whatsoever. Coaches can go in any direction. I personally am very spiritual.
Thank you. And then I'll direct it back to Rebecca unless there's another question here in the live audience. Not at the moment. So Rebecca, I'm gonna, one question here.
Yeah, so I'm interested in, I know that without legal medical aid in dying, that's potentially not an option, but something I have heard of and read about is stopping eating and drinking. I wondered if somebody wanted to address that in terms of how likely that would be to be respected and how much that is a choice that people do take.
I want to make sure that that was caught for the folks on Zoom. The question is related to the decision to discontinue eating and drinking, voluntarily stopping eating and drinking as a means to end your own life, right? And sort of how well respected it is. I'm gonna punt that one maybe to both, maybe Michele, a quick response, and then we can go to Rebecca, and then you could go from there, Rebecca.
Hey,
So,
can you just say what the question was again, please? I heard it was about what about?
The question is voluntarily stopping eating and drinking something that is utilized, respected, what, you know, any sort of anything about it?
Okay.
Yeah, that is something we talk about a lot in my death and dying classes. And for some people that have a known diagnosis, specifically of a neurological disease like a Parkinson's or a dementia or any other kind of degenerative disease, they consider this option because they will not be eligible for medical aid in dying. because of the strict kind of parameters around that. So it is something that there's a lot more about in the literature right now, and there are some pretty significant videos out there about it, research that's going on by clinicians about it. So it's an option that people are taking when they want to leave this life before that disease marches forward and they feel that their quality of life is not going to be acceptable.
Aren't those also part of the post question if you want to have
This is,
additional?
well, the pulse does ask you if you were to be hospitalized, do you want artificial nutrition and hydration? This is a very separate thing where, you know, if I had Parkinson's and said, you know, when I get to this certain point, that will not be acceptable to me. And I won't be eligible for any of these other, you know, I won't have medical aid and dying available to me. So I'm going to explore this, we call it VSED, voluntarily stopping eating and drinking. And so it's a very specific act of, you know, stopping eating and drinking and planning for that. So that life ends before it becomes unacceptable to that person. Rebecca, I don't know if you have more you want to say.
Yeah, thank you, because that really gets right at the heart of the question that I will read, which was, what about someone who has ALS, for example, and is unable to literally lift the cup to their mouth, or can't swallow, so that medical aid and dying is not available to them. So again, this is something that coming to this field as we are, as a new organization, we feel that it's our role to ask lots of questions, and this is a big one. If it's a right, and I would argue it's a human right to have control over our own bodies at the end and through our lives, how can it be my right as someone who is able-bodied to take a medication, but not someone who is disabled in some way, who has ALS or some other, you know, or MS. So it's a really dicey ethical question because of the fears about disabled people being forced into something that they don't want. But in the state of California, which has medical aid and dying, there's a lawsuit that was just filed within the last month from a disability rights organization arguing that the medical aid and dying law was discriminating against them based on the American for Disabilities Act, that they could not avail themselves of the law, of that law, if they did not have that physical ability to lift and swallow. So I think this question we're going to see hopefully open up. We would like to see New Hampshire really being more inclusive as we look at what type of law would be best for New Hampshire around medical aid and dying. And to the voluntarily stopping eating and drinking, as was said, there's a lot of discussion around that now. We have put our website out there as a resource, compiling and curating a lot of this work that talks about questions like this. And you can go to our resources and get linked into the direct sources for a lot of this discussion now. There's also a brand new book called Voluntarily Stopping Eating and Drinking. It's a big book. It's by 4 people who are really been in this work for years and years, medical, a physician, an ethicist, a lawyer, and there's a 4th one that I'm forgetting. You know, people are doing this in the absence of having other alternatives. You know, people are wandering out into the mountains and freezing to death with the absence of other alternatives. People are going out and shooting themselves in the head in the absence of other alternatives when they've decided that their life is completed, they've had enough, their suffering is too much. We don't think that any of those, we respect those choices, but we also fervently believe there have to be more sane and humane ways to treat end of life, where people don't have to worry about making choices and implicating their loved ones in a, you know, a crime scene because they don't qualify, you know, because there's no other opportunity for them. And so I just want to thank you for that question and say, this is the field that we're working in now and really trying to educate ourselves and others. And I'd like to ask you all to, you know, please join us. This is a statewide, grassroots, citizen-driven effort.
Rebecca, is the best way for people to get involved and learn more about what you are doing to go to your webpage for the Alliance? Is that the best way?
Yep, and as with all of us, I'll put our contact information back up there and make one more suggestion that they give everyone give Kate your email address to so we can follow up.
So Laura isn't able to give us the list of registrations without permission. So if you do want to receive any more communication from any of us, I will send out the slides and
What I
information.
can do is I can send some of the information from the chat and the slides if you give them to me,
You can do
to
that
everyone
too.
who's registered by email, and I will include your email address in that, so they can email you if they want to be on that list.
And
Does that
from
make
the
sense?
sign-in sheet? can you
Yes,
also
for
do
those
it
in
from there?
person, we'll
Okay,
use the
perfect.
sign-in sheet, yeah.
Thank you.
Well, we're right around here at 8 o'clock. I don't know
I
if there's
just
any
have
last
one
minute
other
questions.
question. When people don't do a good planning job, and when there has been a death, and the family is really suffering because of that death, are there resources to help the family sort of at least explore or take care of their grief?
There are people who do grief. I do grief coaching, and there also are groups for people to come together. Sometimes people will be so overwhelmed that they'll come to a group and sit there for a year and not even be able to talk. But they'll eventually get to a point where they're there to help other people who are coming in anew. Or they can do one-on-one, and you know, I have something over there that you might want to read about that.
Okay, great.
Because that's another thing of saying it's completely normal. People will say, I'm fine 1 minute, and the next minute I'm on the floor just sobbing. I think I'm going crazy. And part of it is to say, no, this is completely normal, you know? So yes, there are people who are specializing in grief.
There's like a monthly support group at the hospital where I live, and also one of the nursing homes near me also runs a monthly, like, they call it a grief group. And it seems very open to like there were elderly that were there with after their kids died, and younger people after their parents. It seems very full. So I think that was just like in the list of the newspaper, like with the like in the AA section of when all the monthly meetings happen, like it's been there for years.
Yeah.
And when I still worked for hospice, our hospice did offer it free counseling or coaching for anybody, not only for their patient relatives as well. But I think they don't do it anymore. I'm not sure.
I'm sorry, I couldn't make out what you were saying.
Some of the local hospices are providing grief support
Yeah,
to
we used to do
the
Yes.
community.
But they
Yes.
don't do it anymore, I think.
Just hard with COVID, but we are trying to do them as we can.
We
Yeah.
did also have a talk on grief and loss last month, and Laura, I don't know if you can share the links of that, but I think you made that available online.
Not yet. One person, Marcia, I'm
I'm
sorry.
sorry.
No, that's okay. But I did stand up to say that same thing, that we had a panel on grief and loss, and everybody who was on that panel, like these folks, was an expert in providing those services that you mentioned, and so eventually that will be on our YouTube page, so look for it in the next 2 weeks, I would say. I will get it up.
We'll give you 3.
Thank you.
Can I just add that if you know, a lot of what people talked about was having these conversations and talking about it and sort of broaching the subject, and that's a really important first step. And next month, we will be working with Constellation Hospice to provide an online death cafe, which is a really nice chance to have that conversation and have this discussion with a group of like-minded people. So I can share more information as well.
That's
when
great.
Laura circulates,
Marcia,
share the email list.
Marcia was just saying there will be an online death cafe
Yeah,
next month, so we'll circulate that as well.
Yeah.
that'd be great.
So thank you all attendees in person, everyone who joined us via Zoom. Thank you to Laura, thank you to Michele, Sandy, Mary Elizabeth, and Rebecca. I think the format went pretty well, and we're so grateful to have this opportunity. So we'll stay in touch.
Excellent job.
Thank you.